Good morning, everyone. My name is Dr. A. Singh. I will be basically going through the two clinical cases that we managed, and thereafter be handing you over to the rest of the team, which is Dr. Pillay and Fulton, and Sister Renee. Thank you all for coming. The first case, Mr. D.L., a 27-year-old male with no significant background medical history. He presented to St. Augustine's trauma on the 9th of March. He came in with a problem of near drowning, which is most likely secondary to a fall in the bay while under the influence of alcohol. On presentation to trauma, he was hypotensive, tachycardic, he was hypoxic, his oxygen level to 68% on 100% of support. He had a low mental state, his GCS was 6/15. He was intubated and ventilated, and thereafter transferred to the medical ICU for ongoing care. This was his chest X-ray post-intubation. As you can see, there's a right mid to lower zone consolidation. In addition, there were a bilateral ground glass opacification, suggestive of pneumonitis. And as you know, with the near drowning patients, these patients tend to complicate. They get pneumonitis and thereafter progress to ARDS, and they can rapidly deteriorate. In ICU, he had a very poor urine output. He went into severe metabolic acidosis and lactic acidosis and renal failure. His pH was found to be 7.11 with a PCO2 of 48, PO2 of 144, a lactate of 14.1. In addition, his blood test showed marked elevated infective markers. His CRP was 380 with a procalcitonin of 348. He was subsequently commenced on a bicarb infusion, intravenous inotropes, and commenced on CRRT. We started broad-spectrum antibiotics and intravenous diuretics. We prefer to use an APRV mode for ventilation, which seems to be a more protective form of ventilation in these patients. Thereafter, had a discussion with the team, Dr. Diane, Dr. Pillay, and Dr. Fulton, ECMO that have respiratory compromise going forward. In this particular patient, we used cardiac output monitoring. It helped our management in this patient. We used a pico monitor. I think Sister Renee will run through that with you. His hemodynamics improved. He was weaned off ventilation and thereafter extubated, stable state. This was a good outcome, and he escaped the need for ECMO. Just going through the second case. This was a 35-year-old male with no known comorbidities. He presented with a left-sided diaphragmatic hernia repair. He underwent surgery on the 9th of March. It was uneventful. Thereafter, transferred to the surgical ICU. He was ventilated post-op. His post-operative chest X-ray showed no marked infective changes. There was no surgical complications as such. The subsequent day, he started to deteriorate. He was desaturating despite very high oxygen support. Picked up a nosocomial infection. He was tachycardic with a very poor urine output. We increased his intravenous fluids, commenced him on a diuretic infusion. His urine output increased. I commenced him on broad-spectrum antibiotics. This patient never got better. He progressively got worse. His ventilatory requirements were increasing. His chest X-ray showed features of ARDS. He had bilateral air bronchograms. His lungs were stiff, very poor compliance, high airway pressures. In order to achieve the tidal volumes we wanted, we had to have very high airway pressures. And as you know, this is not ideal. These patients, the lung tends to get damaged. You get a lot of barotrauma. His arterial blood gas showed a pH of 7.28, a PCO2 of 63, PO2 of 39. His SATs on 100% support was 63.9. He was struggling, basically going downhill. So then I had a discussion with the team, with Dr. Diane Fulton and Dr. Pillay, and he was an ideal ECMO candidate. So later that night, we cannulated him and coagulated him and commenced him on ECMO. And as usual, we used lung protective ventilation. The ECMO was, we had ups and downs, but I think Dr. Pillay will discuss that with you. He did relatively well. He responded to treatment. He had good lung recovery. He was decannulated with a good outcome. He's still in the ward, mobilizing well. This was a good case, yeah. So I'll hand you over to Dr. Pillay, and you can take the floor.
Hi guys, thanks for coming and making the time for all of this. There's lots of exciting things, and I think as you guys all have experienced, it's like it's a new field where it's bigger than just one person. It takes a massive team, and it's really important that that message comes through. So I'm just going to quickly talk more about the not the drowning patient. I'm going to talk more about the patient that we put on ECMO with a great outcome. I mean, the guy's very young and he's got his whole life ahead of him. So I'm just going to skip that. So, but quickly, we'll just want to talk about team now. So you guys sitting here are actually the ECMO, you know, the guys that are there 24/7 handling, and it's a very slippery slope. So our aim is to, you know, to cook all of each other and work as a team and get feedback, get interaction, and share everything. It's a difficult field where the highs are high and the lows are low, but we share the highs in, for example, this patient that's done phenomenally well, and there's a lot of lows as well. But I think if we all commit and we all just make sure from our side that each individual is not the weakest link, you know, we can achieve like amazing stuff for our province. I don't think the province has seen this kind of organized, collaborative effort. And I mean, you've got Dr. Singh was driving the whole thing. You've got the JJ&J doctors. You've got Dr. Diane. You've got Dr. Del Winters. You've got other collaborators. And we've got, just walking in, Dr. Guila from Bloemfontein. Who's also a very good friend of mine. So before I tell you about that, we're going to, you know, later on, we're going to go down to the Training and Education Center, which I have to thank Renee publicly. A lot of effort. So you guys must see, and it's all for you guys. And we're going to do a structured, organized thing where we've just raised the standard. You know, you raise the standard where this is the default place for people to have good outcomes with this. And it's, you know, it changes lives, it changes everything. So training and education is absolutely crucial. Certification, recertification, and validation, and making sure that we all know what we're doing. It's not a guessing game, it's very scientifically driven, and there's protocols for everything. So I received a call. So I just want to put this picture in the head. It was about, I think it was 10 o'clock at night or 11 o'clock at night. And you get the call, I'm sitting there trying to feed the baby his bottle. And Dr. Singh says, listen, I think we've got to. So recognizing the issue is the first. So you guys are there. You're there with the physician. So when he recognizes it, you know, it has to click. This is what's going on. This is, and he recognizes it. And the problem is if you refer these patients late, you have bad outcomes. You ventilate them for 5 days and their lungs are shot to pieces. ECMO doesn't help. And as Renee says, ECMO is just a pause button. We press pause on the death. So this guy, I'm quite happy to say, in most other places in our region, would have just died. He was basically dead. So we got him on ECMO, we pressed pause, and then the hard work starts. Because ECMO, just putting pipes in someone and getting a machine running, that's not the thing. It's actually managing the thing, attention to detail, and then fixing the underlying process. So that's really important to have that fact, that thing in your mind. Like, what is the problem? We're going to press pause, and then what are we going to do? Because if there's nothing to do, they can't. There's no point. So what happens next? Now I'm sitting there, I put the baby down, give him to my wife. She's quite irritable at this point. and then you activate the team. So the first person I phone is Dr. Fulton. Dr. Fulton sort of drives the team, and he's very experienced. So, Amit tells me I think this. Then I phone Dr. Fulton and I say, okay, this is a story. Then he says, okay, let's go check it out. You have to check the patient. So you get in your car, drive all the way, and then on the way, we phone theater, you phone perfusions, you phone IC, you phone anesthetists, communicate to the referring guys, and you set up all of this stuff. Because when you say go, you have to go. Yeah, you can't then start doing this. And for example, the previous case, the drowning guy, the same thing happened. And we activated everyone, and everybody's running around, and then we said, okay, wait, hold on. But if he needed ECMO, that activation would have saved his life. But in the first case, he didn't. But it's still the same effort. It's the same wood that goes into the fire. It just goes a different way. And the nursing care is critical. I can't emphasize how critical it is. You guys recognize problems. Okay, you guys have to think in a different way. And it's about teamwork. If you're scared of a doctor and you try and do ECMO, it doesn't work. And as Renee always says, ECMO nurses, critical care, especially cardiac nurses, you guys are not waitresses. You're not there to do whatever the doctor says and get screamed at and shouted at. You're there to think. You're there to make decisions. You're there to understand, and you're there to collaborate. So that's the sort of thing we want to do, right? Then you've got to look at the criteria for ECMO. Everybody needs to be familiar with it. Because if somebody says, hey, let's put this guy on ECMO, or maybe he's the case for ECMO, you guys, all of us, we need to say, hey, what are the criteria? Does he qualify? Is there something that's reversible? Because we're just pressing pause, remember? So is there something reversible, and is it appropriate? Now, there's a whole bunch of criteria. If we do that, it's going to take the whole day. But there are guidelines. This is not a thing where it's just one guy saying, oh, I feel, and this. There's very clear guidelines. And we're going to share all of those guidelines with you, and we all must be on the same page. You must remember that the access to knowledge is free. From our side, we just need to, all of us, commit, right? So we get the criteria, and then we go into the cannulation strategy, right? So now we say, oh, okay, this guy's good for ECMO, and we're going to do VV, because as Dr. Singh said, he's got respiratory failure, right? So I take him to theater. So now you can imagine it's now about, even with as fast as we can do it, it's now an hour late, right? With activating everyone on the road. And we stick in a TE probe, and then we sort of say, so we say, let's go do VV, let's set up. So we set up. We stick the probe in on the right side of his heart. Just looks terrible. it looks terrible, it's just not working. So I'm sitting there with the anesthetist and we say, we have to make a split-second decision. Do we do VV and luck, or do we say, no, let's just take over everything, do VA, support the heart, and this I want to tell you guys, it's important to know that experience matters with this thing, and team matters. So the right heart wasn't working, okay? So we said, okay, the safest thing to do is we're going to do VA. And this is two senior doctors. It's myself, who's done a fair amount, and Dr. Justin Dreller, who's a specialist cardiac anesthetist, and he does the ECMO. And we, both of us said, okay, now it's 1 o'clock in the morning. Let's do VA, let's be safe. Do all the things, and the technical stuff is, it just has to be done properly, which it was. And then we take the oath to IC. On the way, I phoned Dr. Fulton. I said, okay, this is where we at, and this is. He's like, I'm on my way, but maybe that wasn't the right decision. And I think that's important to say, because I think his experience, he knew that the right heart was, so it was a safer decision, but it was probably not the right decision straight away. So we just went safe, which I think is not a bad thing. We must remember that. But what happened, as Dr. Fulton said, was the heart recovered very quickly. So it was struggling, we decompressed it, and it recovered really quickly. So does anyone know what Harlequin syndrome is?
You guys watched is it the Avengers? It's not the Avengers. Who's Harley Quinn? It's half red and half blue.
Yeah.
That's a big clue.
So this patient then got Harlequin syndrome. So I'm going to explain to you. Imagine someone whose lungs are not working. So we put this patient on ECMO, and we're putting oxygenated blood from the femoral artery and pumping it this way. But so the heart, usually if it's not working, it's not pumping blood the other way. So it's not an issue. But now this heart recovered, and it's getting blood from the lungs, but the lungs aren't working. So the heart now is getting deoxygenated blood, and it's pumping. I mean, off inotropes and everything. It's pumping deoxygenated blood into this patient's head. And, so then, and coronary artery. So that's a huge problem. So Dr. Fulton and Renee, so you must know during this whole time, it's all split-second decision making. You say, okay, this is the issue, this is the problem. It's how we react that matters. Because now it's 8 o'clock in the morning, patient's relatively stable, and nobody slept. And then you say, okay, we have to go back now, into ICE. And then we say, all right, we have to change back to VV. So we discuss with the team, and then we go back. And we started, I think it was 7:30 or something. You guys were there. Dr. Fulton came to help me. And then we said, all right, let's keep one venous cannula from the VA and put another one in, all right? And we start doing it. But this is the practicality. The guys that were there, you guys saw it. We put the guide wire. Dr. Dreller put the TE Pro, and then it just didn't work. I put the dilator in, it dilated, and then it was bleeding, and then the guide wire didn't want to go in, and then the cannula didn't go in. Now you're sitting there thinking, I'm going to tear this guy's IVC in two. Yeah, this is now in ICU. So you just stop. So once again, team, you stop and say, listen, what's the best option? And immediately swap around and we went through the internal jugular. So we started on the femoral strategy to go to VV. We went to the right internal jugular and we put an Avalon. And we got him onto ECMO. Dr. Fulton will tell you the rest from here. But I just want you guys to see how many points of this journey, we could have killed this patient. If we didn't work as a team, if we didn't, look at the experience, the collective experience, if we didn't move as a unit and recognize danger and have each other's back, because that's what you want. You want a team that has each other's back. And Dr. Fulton, if you can take it from there. Thanks, guys.
Okay, this is just continuing on the same line. The patient was now on ECMO using the Avalon cannula through the internal jugular. And hopefully we can show you an Avalon cannula afterwards to show how it works, where it actually drains blood from the superior vena cava and the inferior vena cava and returns it through the same cannula across the tricuspid valve. So it's taking deoxygenated blood from top and bottom and then pushing it through the tricuspid valve. And that oxygenated blood then travels through the lungs that are not functioning, and then the heart ejects it into the body. So at this stage with VVECMO, you're not imparting any energy to the circulation and helping the heart. The heart is recovering on its own. And we saw this a lot with the COVID ECMOs. The patients would come in often in extremis, and we would CPR the patients onto ECMO, without any regard for what the left or right ventricle looks like. The minute you got them onto ECMO, they were pure respiratory failure, and they got better quickly, and we were able to discharge about 1/3 to 40% of those patients home. So, the ECMO is very effective. Where do we go next one? So this was the first gas, I hope you can see it, where we saw the patient was Harlequin syndrome. So Geron put the patient onto ECMO and got the patient out of immediate trouble. But the blood gas did not improve as we would have liked. So when we sampled blood from the right radial, the patient was persistently hypoxic, the PO2 was 61, the CO2 was better. So getting rid of the CO2 is the most important part of VVECMO in most cases, not usually the hypoxemia. And that's when we knew immediately the problem was that the heart actually wasn't a problem. And bottom left-hand corner there you can see we did it in the unit. So what you can do with these patients, you don't want to move them, and all you need is transesophageal echo to make sure you're not putting the cannula into the wrong place. And when we decided initially to try a bifemoral VV, we had a guide wire in the right atrium. We dilated over the guide wire, but couldn't advance the cannula. And, I've had one patient where you don't have a choice. You've got no imaging, you've got no transesophageal echo, you advance the cannula, you perforate the retroperitoneal inferior vena cava, and basically you kill the patient. So we decided not to do that and then converted to VV through the right internal jugular, also using echocardiographic guidance. And you can't do this without some kind of imaging. If you've got a facility where you've got a C-arm, you can use a C-arm, but the rooms are too small. Transesophageal echo is sufficient. And when I was in Milan, all ECMOs are done in the unit with TEE and nothing else. And they don't perforate things. So we converted to ECMO. This is, the mixing cloud. They talk about, the Americans call it north-south syndrome. It might be easier to understand rather than Harlequin because, so they're talking about north-south. So what tends to happen, from the south, you've got the arterial cannula pumping oxygenated blood, and in the north, you've got the heart pumping deoxygenated blood. And so this just shows you where the mixing cloud is. Your mixing cloud is they show you bad blood from the LV. And so what you're doing is giving deoxygenated blood to things like the brain and the heart, and that's quite important. And it's important to recognize north-south syndrome or Harlequin syndrome. But it's also very important to understand why the patients get it And it's usually because primary respiratory failure without cardiac failure. So again, you know, this is a team decision.
You just go back to that picture. I just quickly want to show the nursing staff something. So I just want you to look at this, and it's important to know the aortic arch anatomy if you're looking after VA ECMO, okay? And this is why. It's to be able to understand this mixing cloud story. So this first branch that comes off the aorta, remember we've got our left ventricle, pumps blood through the aorta, we have our coronary arteries first, and then the very next branch is this innominate artery, brachiocephalic, which supplies your right side. So that's why we're always saying we must compare the sats on the right and left. And if it's poor on the right, it's because the mixing cloud is so far up the arch. It's here in the beginning. Okay. If the sats gets bad on the left side, it means that mixing cloud has moved right through the arch, and that means also your brain is getting that badly oxygenated blood from the native heart. But the native heart beating is it's a good problem to have, because it means the patient's heart is working well. We just need to convert them to the right configuration. But it's to be able to identify where that mixing cloud is. And you'll see it in your arterial trace as well. When you first start with VA ECMO on an acute patient, the arterial trace is quite flat because the heart isn't beating as well as it should. But as that native function improves again, you start having a bit more of a pulsatile arterial line. Then you must already know the heart is working again, and then you must now assess where is this actually. And it's in knowing the aortic arch anatomy where you'll see the discrepancy, the north and south, and then you'll be able to tell whether you need to change over.
We had another ECMO about a month ago, a patient with retroviral disease who started to decompensate progressive respiratory failure and then progressive cardiac failure. And when we were asked to see the patient's pH was 6.8 and was on like supranormal doses of inotrope. And so that patient was global myocardial depression. The left ventricle wasn't working. The right ventricle is often not working well, but as soon as you change their acid-base status and their hypoxemia, it recovers. That lady went on to VA ECMO and stayed on VA ECMO for about 72 hours. But her acidosis reversed, and she started to pass urine and was on no inotropes within 48 hours. So, you know, this is not an uncommon scenario, and I think imaging is important. Imaging tells us how well the heart is functioning. And if the left heart isn't functioning, then you've got to go to VA ECMO. And then these are just these little technical troubleshooting issues that we had as we went along. I think in general, from a pump side, the pump worked extremely well. And the Netcare system is an excellent ECMO system. So, so we didn't really have problems at all with the ECMO machine doing its job. But what we did have is problems, and this is why we want to talk about them, because these are the problems that caused issues. And it's all because of lack of familiarity with the system, the technology, and technical stuff. But there was a problem with getting rid of carbon dioxide. When you put a patient onto ECMO, getting rid of carbon dioxide is not a problem. You can really blow off carbon dioxide in a matter of hours, or even, you know, an hour. You can get someone who's got a CO2 of 100, and they can be back to normal within 2 hours. And that's the effectiveness. CO2 is highly soluble, and so it disappears. But we had trouble getting rid of the carbon dioxide in this patient, and we sort of, it got better, but not better as quickly as it should have. And then one started to get suspicious that there's something going on here. So first thing you do is blame the machine, and there was nothing wrong with it. There were no clots in the oxygenator. Your venous pressure was always very low. Your transmembrane pressure was low, and your pre and post membrane gases were always good. And then we started to think, well, what else is it? So we systematically went through everything. And the first thing was the blender. This is the blender that we used to wean the patient on it. And apparently there was a problem with it. And the one thing that was done, which you probably shouldn't do, is we tried the Robinson Crusoe, Heath Robinson effort by putting tape on the system, and it seemed to work a bit better because the connection wasn't good. The kind of default is you should take it off that and put it on the wall. So, which is what we did. So you put it on the wall, but it had two little branches on it. So we then realized that it was still not okay. We still weren't getting rid of carbon dioxide. And then there was, no, maybe we must change the ECMO circuit. And we actually primed another circuit. And then we took that one off the wall and put it onto a single outlet, and everything got better. And when we looked at that blender, the one side that we were using, there was some kind of obstruction in it as well. So these are all the things that you've got to realize you can be sabotaged by equipment when things don't make sense. We also had issues with the ventilator, and I think then Dr. Singh came and just changed the whole ventilator. So, they're all the things that will trip you up. An ECMO run can be absolutely like flying a plane. It's take off and landing, get up in the air, fly the plane, take them off ECMO, and they go home, and nothing happens. But where I think this particular case was very helpful, and I think all the staff involved were tremendous. It was a nice dialogue we had all the time with WhatsApps, and we got a lot of information to and fro. But the troubleshooting took place on a very immediate basis. When there was a problem, we didn't sleep much while the patient was on ECMO because we always got the messages. And I think that was the key, that we had continuous feedback, continuously asking questions and adjusting anticoagulation, adjusting ventilation, looking at the gases and saying there's something going on here. So I think that the technology can trip you up. The other problem was adequate sedation. We saw again in COVID, they were a problem to sedate even the ventilated ones, and I'm sure you probably found that. Some patients consumed sedation. We're not sure why on the non-ECMO patients, but it's quite well described that VVECMO patients require enormous amounts of sedation and all kinds of sedation strategies to try and get the patients adequately sedated. We ended up with Dormicum, morphine, ketamine, Presidex. There's been a hesitancy to use Diprovan because the feeling was that it gets sequestered in the membrane, but we never found it to be an issue. And we probably did 300 ECMOs over that COVID period. And we used lots of milk of amnesia to try and try to avoid. And we would try these regular sedation holidays, and the patients some of them would just climb the walls and try and pull the cannula out. We had to keep them deeply asleep. We tried to avoid paralysis as much as we could. But the patients appeared asleep because he was paralyzed. And the only clue became hypertensive and tachycardic. And then his gas exchange got a bit funny because they Valsalva, and that interferes with pump flow. And the only clue was the monitor telling me, but he's asleep, but he's not. So it's really important to remember these patients need a lot of sedation. It doesn't mean to say they all need sedation. Some of them we were able to actually extubate on ECMO in the COVID. And in Milan, it was their routine. You put the patient on ECMO and extubate them, usually within 6 hours. But that's, again, an environment where they do hundreds of ECMOs a year. Why is it not going? Oh, there we go. Then the other problem was deterioration after doing really well for a period of time, and then we had problems with the ventilation, airway pressures were high, tidal volumes were falling. Remember, the patient had a thoracotomy. He'd had a chest drain put in by the original surgeon, and then Dr. Augustine had put in another drain. He was asked, the first time he was asked to see the patient. That drain was then removed after several days. We then had this deterioration in his ventilation parameters, with tidal volumes falling from over 300 to 140. And a slow fall in the hemoglobin, not a precipitous fall. And we also had some issues with the heparin line, where it appeared to be ineffective and the patient was getting actually too much heparin. So we overshot on APTT. We did a chest x-ray, and then you had a whiteout of the left lung. So the feeling was we should bronchoscope him first, because it may be a mucus plug. Dr. Pillay bronchoscoped the patient. There was a lot of muck there. We did an x-ray which showed what we thought was a gas shadow in the left apex, and thought, well, you should have a CT scan, but didn't want to move him at that stage. Asked the radiologist to comment, and he said, no, it's bowel in the chest. So we thought the hernia had broken down. And then we sort of were a little ambivalent at that stage about going back, but we had to go back. So we took him back to theatre, and he had a massive hemothorax. So he'd had a massive secondary bleed, probably from the first thoracotomy site, which was through the pectoralis major muscle, which is not the usual site. It wasn't from the chest drain. So we evacuated that clot, and we decided not to anticoagulate the patient anymore. We'd had a secondary bleed, and on high ECMO flows, you don't need to anticoagulate the patient for 3, 4, 5 days, as long as the flows are high. And these are bonded circuits, so the risk of thrombosis is relatively low. And with the polytrauma patients that we used to put onto ECMO for acute onset ARDS from pulmonary contusion, we ran several of those and did not have any major bleeds from it. Probably about 7 patients that we saw. So, it's anyway. Just to show you, this was Dr. Singh showed this X-ray, and the bottom X-ray is the last X-ray before we took the patient off ECMO. He did have a small extrapleural hematoma left, and as you can see, there was a dramatic improvement in his X-ray. His lung compliance had virtually normalized. His gas exchange was excellent. He was on 35% FiO2 on the ventilator. We didn't do the usual. We're supposed to drop the flows to 2.5 liters. We said we'll leave it at 3.5 liters, and we switched the gas flow from the wall off. So basically what you had was the patient circulating blood through a membrane that wasn't doing any oxygenation, wasn't doing any carbon dioxide removal. And after 24 hours, we took the ECMO out, and he has done extremely well since then. Just Dr. Singh did mention APRV. This was the preferred method of ventilation, and we talk about injurious ventilation. We've seen patients being ventilated badly for 6 hours, and it results in irreversible lung injury. And I think COVID has made that even more obvious. So ultra-protective lung ventilation using APRV. APRV is just a lot of PEEP for a long time with a little break in between. And that's really what it is. So it's got a nice name, but it's just like PEEP ventilation. And if you hear the high-volume centers in the United States and Europe talking about their ECMO referrals, they get asked to see a patient with ARDS. And most of the time, the problem is the patients are not being ventilated properly. And a lot of the time, the PEEP is too low or non-existent. And they were able to abort 90% of ECMO referrals by using APRV ventilation. It's not perfect for everybody, but it certainly it made a big difference. And although the literature doesn't show, I stole this from Guy Richards, who knows a lot more about this than me. And it says no study showed decrease in mortality versus protective ventilation. But it appears to dramatically change the course of a patient's ventilation. Are there any questions? And I just want to say that it was great doing this with everybody. It's difficult doing it from a distance, but I think that in spite of that, we managed to salvage a young patient. And I think the key was early referral by Dr. Singh, and being malleable and realizing this is not a straight line to the finish line. There's been lots of detours along the way. We had one patient, I think, that we operated, did 5 different thoracotomies on the patient, and you start to think, how can you operate on someone on heparin, on ECMO? You can. And they will live. Bronchopleural fistulae, bleeds, all kinds of things. So, yeah, you can.
Okay, cool. I've only got a very short bit, so don't panic. Oh, we wanted to show you guys these resources that are most helpful. We use them all the time, but I think as if you're new to ECMO, this would be the most recommended one is probably the Alfred guidelines, which we asked all the nursing staff to download. They give you everything from the nursing care to the daily ward rounds, all the criteria. It's a high volume center. I think they do something like 200 lung transplants a year there. And in their program, I think from the call, from Please Help with ECMO, they guarantee the patient can get onto ECMO within 30 minutes in their center at any point. So they're really well experienced. So we are going to copy and paste everything that they know to our program. I don't know if we'll do it as well as them, but we'll use their knowledge. Okay. Parasitize. But that's a really good guideline to check out, especially if you're in the moment looking after the patient. And then these are some of the podcasts we also listen to for some extra information. And then, of course, ECMO is associated with the Also Society. And we fall under this SWARC chapter, Southwest Asia and Africa chapter. But you can also find all the information on these groups' websites. So please check it out if this interests you. I just quickly wanted to say, there's many indications, contraindications, complete contraindications for patients, but I think this is just a nice, simple way to start it off and when to think about ECMO. And ECMO should be considered whenever a young patient, so that's someone under 65, acutely deteriorates with a potentially reversible cardiac and/or respiratory problem. Just to put it in a nutshell. If you see that, refer to the ECMO team. They will do that more specific assessment and then take it from there. Not to make things too complicated. That's a good place to start. But if you want to get complicated, this is the patient selection tool on the Alfred's guidelines. And I thought maybe we could just quickly go through it with this case that we're talking about now. What you do is you determine this risk score from a diagnostic group in category 1, the clinical modifier in 2, ensure no absolute contraindications in 3, and then you use the number 4 to figure out the expected outcome for the patient. Okay, so if we have a look at this patient, we probably think he had ARDS, right, to start off with. So he will get a diagnostic group, he will get that score over there, which is 1. You'll see the score goes up. Here's our ECP pneumonias and all sorts of respiratory issues, either get a 1, a 2, or a 3. The higher up it goes, the more unfavorable it is. So he was in the favorable diagnostic group, so that was great. So he got a score of 1. The clinical modifier, I think we did have a lactate above 10 to start off with, and he was on inotropes as well. He wasn't anuric, he just had a low urine output as far as I remember, so maybe we could add another 2 there, 1 for each of those. He had none of these comorbidities, so far we're on about a 3 score. If we look at the absolute contraindications, he didn't fit any of these. And on the Alfred's guidelines, they have an age of 75 as an absolute contraindication, but 65 being unfavorable. If you're 65 and higher. So he didn't have that. So if we've got the score of 3, and his age group was under 40, we're nicely in the green zone here. Good expected outcome. Okay, so he was a very good candidate and referral from Dr. Singh for ECMO. Okay, so this is available. It's on. You can have it on your phone and you can quickly work it out. It doesn't take very long. And then some of the nursing staff shared this with us, but I thought I'd share it with everyone. And that is this. This is the patient a couple of days ago. Okay. And we just wanted to say thank you very much to the nursing staff for embracing this huge challenge and being part of that very chaotic WhatsApp group, even though it was very effective. You can be very proud that we made a huge difference in this patient's life. We're sending a patient probably back to his family with good quality of life and a future. So you can pat yourself on the back. That's why we do this job, isn't it? Actually. Yeah, I think we've probably run out of time to talk through the cardiac output monitoring on the other patient, but I will invite you to maybe just check out. We did record a cardiac output Q&A the other day where we used the same patient, and I did speak about it on there. But basically, by adding the cardiac output monitor, you can make very confident decisions about inotropes, about pressors, about giving fluid, and about giving diuretics. And as soon as that starts getting confusing, it's really worthwhile to add the cardiac output monitor. And we were able to halve the inotropes very quickly, prevent him from getting organ dysfunction, and he quickly made a recovery. And it was all from interpreting that data. So I really encourage you guys, if you start feeling like you're not sure whether to give fluid or go up with inotropes, just add a cardiac output monitor and let it help you make the decision before you make a mistake and put your patient into pulmonary edema. And it was very challenging with the near drowning. It was very exciting and fun for us because we had just done a cardiac output workshop, which we will repeat again with you guys as well. But we already had existing pulmonary edema and a very dry patient. So it was very difficult to manage his blood pressure without the confidence from the cardiac output monitor. So it made a huge difference in that patient. But if you're interested, like I say, check out the Q&A on our YouTube channel on cardiac output, and we used a lot of that case in that.